Thank you. Thanks, Annika. Hi, everybody. My name's Jane Robb. I'm one of the clinical trainers in BEAT. I work predominantly with families. I do carers groups with families of loved ones who have an eating disorder, from children and young people up into, we're currently also doing a one for people who've had eating disorders for 5 years plus. We also do and deliver training to schools and to primary care settings. And I'm here today with my colleague, Tracy. Tracy, can I hear you?
No.
Yes. Yes. No. Yes.
Oh,
yes.
That's weird because you heard me earlier, so that's very weird. Right, earphones out. So yeah, so my name's Tracy, and I'm essentially the other side, exactly what Jane had said. Really, I'm one of the clinical trainers at BEAT. I suppose the probably other important thing to note about both of us really is, previous to working for BEAT, we're both mental health nurses and worked within eating disorder services prior to coming over to BEAT. So yeah, so that's who we are. I'm going to start, aren't I, Jane? Yeah. So if I do the first, get the first slide up. There we go. Oh, thank you, Annika. So for those of you who don't know BEAT, I won't tell you kind of too much because we've obviously got kind of time constraints, but we are the UK's leading eating disorder charity. So really worth having a look at our website, which we will tell you a little bit more throughout, because that has an awful lot of resources that's accessible to everybody. So well worth having a look if you don't know about us already. But I am aware a lot of people are aware of us. And like I said, I think Annika said, you're getting a copy of these slides anyway, so you will have all that information. So I guess don't worry about taking it all down at this point. So if we can go to the next slide, Annika, that would be great. We're actually focusing on eating disorders and rather than disordered eating, and we really wanted to try and think about how you differentiate between eating disorder and disordered eating. What I would say at the beginning of this is what you'll probably see is there's not a nice little straight tidy line for that. It's all a bit kind of wiggly, so there are some crossovers, but where disorders, what we thought was probably important to concentrate on was actually diagnosis, because that's what we're talking about when we are talking about eating disorders. And we thought we'd kind of start by just thinking about, what are the causes to eating disorders? And the main thing around that is understanding is there is actually not just one single cause to an eating disorder. It's a mental illness. It's a complex mental illness which has complex risk factors, probably, rather than causes. So Annika, if you want to press it again, and they should all come up. Thank you. So some of the kind of risk factors that we look at in relation to predisposing factors of eating disorders, we look at genetic, psychological factors, biological factors, environmental and social factors. When we look, I'll just quickly kind of, like I say, it's a bit of a whistle-stop tour, so I'll quickly kind of go through these. When we look at genetics, we're not saying that what we know about the genetics is there's not an eating disorder gene. Oh, sorry, I'm getting a bit of feedback, so I was just going to say if people could themselves on mute, that would be great. Thank you. So there's not one gene that causes an eating disorder, but there's actually genetics that might determine somebody for a higher risk factor of an eating disorder. So things like that dictate our body shape and our metabolic rate. But also what we're aware of is that there are a cluster of genes that seem to relate to increased risk factors for eating disorders. But like I say, not one gene that exists. And then we look at the biological factors, and that's essentially things that are going on within the brain. We still don't know much about as much about the brain as we'd like to, but we know that there's actually biological factors that influence risk in relation to eating disorders, but also in relation to starvation, which we'll be talking about later on. So it's important to understand that structures in the brain influence whether somebody is at risk of an eating disorder. Then we look at environmental factors, and these are things that people are probably aware of anyway, such as media influences, cultural influences, which, like I say, kind of people will be aware of already. Some social factors, so Bullying might be one of those factors, body shaming, early life experiences, abuse, neglect, and then psychological factors, just things like distorted cognitions, factors including unhealthy beliefs about self, low self-esteem, perfectionist personality traits would be seen in those psychological factors. So that's just, like I say, a bit of a whistle-top story about some of the causes of eating disorders, and the important takeout is not just one cause, and these are risk factors rather than all of these things are actually what causes eating disorders. I'm going to hand over to Jane to just focus a little bit more on the diagnostic criteria. So that would be the next slide, please, Anne.
Thanks, thanks, Tracy. So we're just going to focus on the 3 major eating disorders at this moment in time for the purpose of this session. So anorexia nervosa, bulimia nervosa, and binge eating disorder. Excuse me, these are mainly the 3 eating disorders that your eating disorder teams will work with. We know ARFID has also now come into the diagnostics of eating disorders, but not all teams work with that. And I know there's going to be a session on that a little bit later. So we're just going to focus on these 3. Next slide, please. So anorexia nervosa, this is probably the one that you're more familiar with. It's the one that I guess gets more publicity around because of maybe how people look, and it's often out there in the media. But what we need to know about this illness is that it does have the highest mortality rate of all mental health conditions. That can be quite frightening to hear, but due to its physical aspect and its psychological damage, there is a high risk of suicide in this group. So physiologically, when people are starved, obviously their bodies take a lot of pressure through the starvation, and that can end up in lots of physical complaints that could eventually lead to death. In anorexia, we know that people use food and weight to evaluate themselves and their worth. So if you think about, you know, putting all your eggs in one basket, it's all what's important is your weight and your shape, and then you've got nothing else in your life. That's what you focus on. So it's really where people become very isolated, and they put everything that they're worth within that. And there is an intense fear of weight gain. Within anorexia, the behaviours that people can present with are that they can restrict the food intake, and that can include fluids. So this becomes very physically risky. People often end up having to be admitted into medical wards for physical stabilisation. Other behaviours that people may pick up on and that you don't see, because this is something that they can do very much in private and very much in the head. Because once, I'm sure, if anybody's been on a diet, you're going to know exactly what calories are in what foods. And what once you've learned that, it's really difficult to unlearn it. So then that becomes really obsessive with people counting calories, especially when in all the eating disorders, but particularly within anorexia. We also see lots of food rituals, such as cutting food into small pieces and having to use special cutlery and crockery. People can get very fixed on times that they have to eat at a certain time. So they say they have to eat lunch at 12. And if for some reason it gets to 12:05, then they won't eat it because it's gone past that time. So they become very rigid as part of starvation. There's lots of things that affect the brain and affect the behaviours. Sometimes you do get compulsive exercise, not everybody, but it is probably quite a big driver in anorexia. We know that people often weigh themselves and weigh the food, become very specific about that, about how much milk they need to have, how much grams is in a packet of cereal, etc. They become very isolated, so that again buys into their mental health, into their depressive type state. They don't socialise, they avoid social situations because they can't eat when they're out, they don't want to eat in public, they've got lots of rules and rigidity going on. So it has a massive impact on the social impact of somebody's life. They do keep busy in the things that they like to do. And generally we know that people with anorexia are quite perfectionist by standards. So they overwork, they're very intense in their study. But this links into starvation as well, because the starved brain obviously is very difficult to try and retain information. So people work really hard, particularly when, you know, young people are doing their exams, whether it's school or at university. They're very fixed in this, but that's probably because the memory isn't great. So they get very focused on it because they're not going out, they're not engaged in any other social activity. So it is the only thing that they feel that they're good at, but they have to do it a lot because of their concentration levels due to starvation. They often believe that they're fat when they're very thin, but some people aren't very thin. Some, you know, your weight isn't the only thing that you can go off. You know, you need to think about a bigger complex of how we're going to talk about risk assessments in a little while, but it's not just on weight. There's lots of things that can assess if somebody has an eating disorder. And again, one of the risks is that they constantly compare themselves to others. So they will always be body checking with somebody else. They'll be doing their own body checking behaviours, which could be, you know, just measuring around their wrists, measuring around their thighs, measuring around their tummies, watching whatever's going on YouTube. You know, some sites are helpful, some sites are really unhelpful. And then we know in anorexia, there's these two subtypes. So there's the restrictive subtype, which is where people restrict their intake and probably over-exercise within that. And then there is a subtype where people can binge and purge. And that sometimes is where it gets a little bit complicated, for particularly in primary care. So somebody will present and with an eating disorder and say they're being sick, and then immediately say, well, you've got bulimia being sick. But it's not. People can binge and purge in anorexia as well. Obviously their weight is determined in that they're very much underweight. And when the purge, they can purge after every meal, even the small quantities that they're eating. Next slide, please. So in bulimia nervosa, so this the diagnostic criteria for this is a recurrent binge eating followed by compensatory behaviours to avoid weight gain at least once a week for 3 months. So when we talk about compensatory behaviours, we talk about laxative abuse, diuretic abuse, exercise, anything that somebody can use to try and get rid of the food that they've taken in. So anything that anybody wants to do. Bulimia is always a bit tricky to try to identify, because normally body weight is in the normal range or fluctuates but doesn't significantly go down into that starved state of anorexia. People will describe a loss of control over the binge eating episodes. They're normally quite planned, they're normally quite routine of when somebody will have a binge, that, you know, they'll be very particular about what food they're going to eat, about what bowl they're going to use, about what time they're going to do it. But they do feel that there's an element of losing control within that type of behaviour. The compensatory behaviours, like I've just mentioned, to prevent weight gain. And this is physically, this is the one where they may have dental issues, esophageal issues, gastrointestinal symptoms. So again, sometimes having conversations with dentists is really helpful, because they could be the first people that actually identify there's a problem going on, because when people are sick, it takes off the enamel off the teeth. And that's quite a good one that dentists can sometimes try and have a conversation with somebody. And again, it's, you know, there's risk in all of our eating disorders, but bulimia particularly is a little bit of a silent killer because of low potassium. So when somebody is purging quite frequently, that affects the potassium levels, which can affect the heart. And you don't know that. You can't see looking at somebody that they've got low potassium. So it's a one that you really have to manage quite carefully. If you know that they're having this behaviour, engaging with their GP, engaging with the primary care setting, etc., to try to look at how you can best manage that. Bulimia brings in lots of feelings of shame associated with purge behaviours. It's a very shaming illness, and it's a one that people don't regularly talk about very often. Again, self-esteem is significantly influenced by weight and body shape, and they do have body image disturbances to this. Bulimia is probably a one where you'll find males suffer from more than anorexia. There is a percentage of males have anorexia, but it's a higher percentage of females. Bulimia probably has more male sufferers than what we would normally see. Next slide, please. And then the third eating disorder that we wanted to just cover today was the binge eating disorder. So again, diagnostic criteria for this is that sufferers binge on a very large amount of food for at least once a week for a 3-month period or more. Again, 43% of sufferers are men. Binges tend to occur in secret. They're not influenced by feelings of hunger. There's initial sense of relief when people have a binge, but that's often followed by feelings of self-loathing and shame and guilt. They may be overweight or obese, and they don't purge. So they sit with the feelings as part of a punishment. So when they overeat, the feelings that they've got of shame and disgust and self-loathing, actually they sit with them as their reason as to why they've done what they do as a punishment. It can often lead to periods of diet restriction, and sufferers may have had a previous eating disorder. It's not unusual for people to move through the family, I guess, of eating disorders. They could start off with anorexia and move through into bulimia, or start with bulimia and move through into binge eating. It's not unusual that people move through the 3 eating disorders. Next slide, please. Will you press this twice because they all come up on this one? Thank you. So other eating disorders that you might have heard of, OSFED. So this used to be called EDNOS or atypical. It's now called other specified food eating disorders. And this is where people probably have a diagnosis similar to anorexia or similar to bulimia or similar to binge eating, but they don't fulfill the whole of the criteria. So they might not be binging as often to fill criteria, or being sick as often, or as low body weight as what the diagnosis for anorexia would be. But there still is an eating disorder within that. And that's probably the biggest part of the population who have OSFED, to be fair. That's probably what you probably will see coming up into services. ARFID, I know there's going to be a session on this later on today, so that's avoiding restricted food intake disorder. This is where people have a feeding disturbance and avoidance based on probably sensory needs. So there may be some autism diagnosis connected to this, not always, but there may be. Orthorexia, this isn't a diagnostic criteria, but you might hear of it. It's where people have very, they stick very much to clean eating. And it becomes very unhealthy because they take out all the other regular nutrients that everybody needs in their daily lifestyle, pure healthy eating. Rumination, this is where people regurgitate the food. So they regurgitate it, they re-swallow it, they regurgitate it, they re-swallow it, they could spit it out. You do get that presenting in some clinics. Pica is where people eat foods that aren't of any significant nutritional value. So some people might eat hair, dirt, charcoal, etc. So things that don't really give you any energy or anything of substance, but it is classed as an eating disorder. And then we have TIDE, which is type 1 diabetes within eating disorders. And people with diabetes may restrict their insulin to control their calorie intake and their weight. Next slide, please. So when we're looking at a definition of eating disorders, we can recognise that it's something that people use as a control around food, weight or shape as a means of managing life. In BEAT, we talk about feelings, not food. And the reasons that people can do this are identified here. So, they may over control or under control their eating, use as a coping mechanism, have maladaptive eating behaviours, use it to deal with difficult emotions, be quite preoccupied with food, shape or weight, and end up with a serious mental health condition. Next slide, please. And just as a takeaway sign from my bit, really, when we talk about warning signs, BEAT have got this poster which really just gives a good vision of how to think about things if you're worried about anybody with an eating disorder. So you talk lips, are people obsessed about food? Are they talking about food? Are you noticing that the change in their eating habits? Flips, is the behaviour changing? Are they starting to be withdrawn? Are they not engaging as often as they used to be? Hips, do they believe that they've got distorted beliefs about their body size? Are they making comments about that? Are they doing anything that would sort of bring your attention to that? Kips, are they often tired? Do you notice that they're trying to struggle with concentration? Nips, do they disappear up to the toilet after a meal? And then skips, have they started excessively exercising? That's probably quite a good little, it's available to download on the BEAT website, but it's quite a good one just to identify warning signs. I'll now hand back to Tracy, thank you.
Thank you, Jane. Sorry, Annika, are we doing okay for time? Just okay, fabulous. I'm just going to kind of run through some really take homes, really, some tools that you can kind of use, hopefully in all of your areas, because I know we've got quite a mixed bunch here today, so I've tried to kind of cover it as much as I can. But just some kind of tools that are out there that you can familiarise yourself with and use to, if you do suspect that somebody has an eating disorder and you want to kind of you want to encourage more conversations and want to find out more. So I'm firstly going to go through some of the screening tools. You can see the QR code, so if you want to kind of get that down and keep a copy of that, and I'll let you know where those are kind of leading to. I think there's a few QR codes as we maybe go through here. But these are, like I say, these are screening tools. They're not assessment tools. They need to be used in conjunction with your own kind of clinical judgment and obviously kind of other information that's out there. But what they are good for is, like I say, to generate further conversation. So if you're not sure where to start, you could look at these kind of screening tools and think, actually, these are the type of questions that I can ask as a screening process, or even just think about yourself. Have you noticed some of these things with some of the young people you might might be working with or come across or be the parent of. So this first kind of tool which the QR code relates to is the British Medical Journal Primary Care Infographic. This is a really, really nice one. It's essentially kind of a great walkthrough guide on what to do and steps to take if a young person is presented with a suspected eating disorder. Although the focus is on young people, it could also be something that can be used with kind of older young people. I know it's all young people anyway, it's under 25s. I think everybody kind of here, I'm imagining, kind of works with, so it would be appropriate. The other one I've mentioned here is the SCOFF questionnaire, which and the ESP, which I'll go through. Oh, thank you, Annika. So this is just to give you an example of what the SCOFF questionnaire looks like. Some services ask for you to complete this if they're looking at a referral. And like I say, it's just about generating conversation. So it's not an assessment tool. It's just to become a bit more curious. And the idea is that a score of 2 or more yes answers, ask more questions. We need to be thinking about, is this an eating disorder? So it doesn't say it is or it isn't. It just says, oh, it could be. So questions are, do you ever make yourself sick because you feel uncomfortably full? Do you worry you have lost control over how much you eat? Have you recently lost more than 1 stone in a 3-month period? And do you believe yourself to be fat when others say you are too thin? Now, they are very direct questions. They're meant to kind of be, and some people might feel really uncomfortable about asking those, but sometimes when you present it as a questionnaire and a screening tool, it can be easier just to ask those. And like I say, it's about having further conversations about these, and you can present them in that way. Actually, these are really direct questions. I'm just going to ask them how they are on the questionnaire, and I'm just really interested in what kind of the answers are coming back. So I hope that kind of makes sense. So Annika, could you move to the next, please? The next one is the ESP, and it's the eating disorder tool for screening for primary care, one that's often given to GPs. But again, you don't have to just work in primary care to use these tools. It is about, like I say, generating kind of thoughts and hopefully kind of conversations. So they're asking questions to, are you satisfied with your eating patterns? And as it kind of says there, a no to this question is classified as a normal response. So ask more. Do you ever eat in secret? If it's a yes, again, kind of let's explore that a little bit more. Does your weight affect the way you feel about yourself? Have any members of your family suffered with an eating disorder, and do you currently suffer with, or have you ever suffered in the past with an eating disorder? So again, really quite direct questions, and might feel quite difficult to ask, but the fact that it's with a screening tool can sometimes be a little bit easier. If you could move on to the next slide, Annika. Thank you. And then just looking at risk management guidelines. Now, I'm not going to go into this because this would be a mammoth session, and we just haven't got the time to do that, but something that's really worth being aware exists. So the MEAD guidance, which is medical emergencies in eating disorder, previously you might have heard, you may not, it doesn't matter if you've never heard of these, if you're in certain professions you would have, but there was something called marzipan and junior marzipan. These have been superseded by this MEAD guidance. This is a new guidance which just really looks at risk management in eating disorders, and really looks at the physical risks and thinking about what you need to be mindful of in services. And the QR code there just leads to a nice little pocket guide, which is well worth kind of having just in your, whether it be on a wall or just kind of within folders, just to be aware of. Now, the good thing about the MEAD guidance is there are snippets in there, so there are appendix there for everybody. So there are appendix kind of in there for how to kind of manage risk if you're a dietitian, how to manage and be aware of risk if you're a parent, how to manage risk if you're a sufferer of an eating disorder. So well worth familiarising yourself with not the whole document, but just the fact that it actually exists. And then there's other risk management guidelines as well. So here we've got the guide to medical risk for, I can't kind of see the rest of that. So, and the general practitioner's guide to eating disorders, which was produced by the College London in 2009. So again, I'm not going to go into big detail because it would be a whole session in itself, but I'd say the key one there would be your MEAD guidance. So if we can move on to the next slide, please, Annika. And then just probably worth knowing some of the services that Beat have on offer for families and carers, again, in hope that you can kind of use some of these services to signpost people to or utilise kind of yourself. Again, not going to go into all of these. These are obviously, you'll have the slides, so you'll be aware of some of the services that are out there. The two that I will go into or just speak about a little bit more, the two that are highlighted in yellow, because these are the ones that are currently commissioned in Surrey. Places are limited, unfortunately. But we are working hard across the nation, really, to try and get these funded across the board. But that's just not been possible at the moment. And there are different periods of time where we do get grants that mean that that is possible. So always worth looking out for. But Endeavour is the first one, and that's an 8-week support programme for carers, and that's run over Zoom. And that's for people aged 5 to 15 who have either been diagnosed with ARFID or are presenting with symptoms. So you don't actually have to have a diagnosis, and up to 2 carers per 1 young person can be supported in a safe space. And that's those are facilitated by programme officers. And that's a self-referral. So carers can be signposted to that or look at the Beat website. All of this will be available on the Beat website. And then we have Developing Dolphins. This again is a carer course. It's a 5-week skilled-based training. This is facilitated by clinical trainers, so people like myself and Jane, and that is via Zoom. And this is to help carers learn new skills to help manage and support their loved ones who are experiencing an eating disorder and support them through recovery. This is self-referral, but you have to be guided by a clinical team. And that's due to commissioning, not due to kind of Beat, but just being aware. So if you are under a service or working for a service, kind of just be aware that these are available to you. Could you move to the next slide, please, Annika? Thank you. And again, I'm probably not going to go through these, but just being aware that these are some of the services that are available for people with an eating disorder. And if you go to the next slide, Annika. And this one I'll probably focus a little bit more on, because this will probably be more relevant and something, again, you can access at this point. One of the things that we have on our Beat website is something that's called POD. So that's the peer support and online development. That's for all carers. This is free to access. And this is a platform which has lots of e-learning kind of resources. It has webinars. It has forums where people can chat to each other. It has somewhere where you can ask clinical trainers questions. So it's really, really worth kind of signposting, and that's something that anybody can access. Any carer, sorry, can access. So anybody can signpost, and is free. So there's no remits around that other than being a carer. And there's a version for school professionals. And yeah, for school professionals called Spot, and that's similar to POD. Again, kind of has lots of e-learning resources, forums where people share resources, ask questions, and is again, that's for anybody who's working within a school. The other things we offer are Beyond the Symptoms, which are tailored one-day education packages facilitated by clinical trainers, which talk about eating disorders in much more detail and how to spot and manage those, particularly in primary care settings. But that is a paid service, so something that does have to be paid. And then we have COPS, which is the Community of Practice Sessions. So that's in combination with Health Education England, and that's education sessions for GPs and primary care. Again, this is kind of free and accessible to all those working within primary care, and it's just to boost kind of knowledge and confidence and understanding of eating disorders. And if you move to the next slide, please, Annika. The other useful resource that's probably worth being aware of is Help Finder. So again, if you go on the Beat website, you can just look, if you looked up Help Finder, what you can do with this is you can put your postcode in, you can put, so if you're caring for somebody who's got binge eating disorder, or you're suffering with binge eating disorder yourself and you want to look at services that are available in your area, you put your postcode in, you put the area of support that you're looking for, and it will tell you all of the services that are available in your area that have kind of registered with Beat. So that might be health services as well as kind of private services and third sector as well. And that is, you don't have to register for that. That's just something that you can access, whether you're again kind of a carer or professional. And next slide, Annika, is that us done now? Yeah, I'm not, that's just further Beat resources. I'll probably leave people to kind of look through that themselves, just being aware. That would just signpost people more to certain resources that we felt might be helpful at this point to look at in your own time.
Hi everyone, my name's Michelle. I'm a dietitian in the Children's Eating Disorder Service in Surrey. I also work across the SIPS CT teams, previously known as CAMS. So I'm going to talk a little bit about our services and disordered eating. Next, please. Yeah, that's next, please. Sorry. So I'm not going to go too much into this because the ladies from Beat have done a really, really good job of summarising this. But something that I did want to kind of mention on top of that is that when we think about eating disorders and how we diagnose eating disorders, we use the diagnostic manual, and there's a set of criteria for the different eating disorders, and that's what is used for diagnosis. Next, please. So in the Surrey Children's Eating Disorder Service, we get about, on average, 44 referrals a month. This fluctuates, sometimes less, sometimes more, but we, on average, only assess about 22 of them. We accept referrals from GPs, other health professionals like paediatricians, other SIPS CT teams, and also self-referrals from parents. We take those referrals to a referral meeting where we screen them. It's important to note that you don't need to be underweight to meet the threshold for an eating disorder. Eating disorders are much more complex than that. You can also be significantly underweight and not have an eating disorder. So there's been times where we've had assessments and the young person is really underweight and it's not an eating disorder. So weight doesn't determine whether someone has an eating disorder or not. We look at behaviours, cognitions, and physical symptoms, and timeframes of these changes. And as a team, if we suspect an eating disorder, we ask them to come to an assessment, and we do that within 15 days of the initial referral. So we see them quite quickly. Next, please. So the treatment pathway in SEDS, the assessments are actually quite long. They last about 3 to 4 hours, so most of the morning. So the screening process is quite rigorous to kind of people through these assessments, which are quite long. We do the treatments that we do are family-based treatment, or FBT, systemic family therapy, individual therapy, CBT, SSEM. We have a separate pathway for ARFID, FBT, which is a family-based treatment that has the best evidence for recovery, and that's the main treatment that we use. However, this is only 60% success rate, hence the other treatments that we have. We provide regular reviews with our team consultant psychiatrists to consider care plans, trajectories, and on average, young people are in our service for between 6 to 18 months. We also offer groups for young people and their families, so parent support groups, body image groups, and those types of support as well. Next, please. So how to refer to SEDS? There's, as mentioned before, there's GP referrals, internal referrals, and parents can self-refer. Please don't wait if you suspect an eating disorder. I'm not going to go into the lips, hips, but we suggest thinking about those things. And if an eating disorder is suspected, you can make a phone call to us and talk to a clinician. Next, please. As of today, we have about 176 young people under our team, and you can see there the majority of the people under our team have the diagnosis of anorexia nervosa. a lot less for the other kind of eating disorders. Next, please. So thinking about disordered eating, and this part can be quite confusing, and I guess what I don't expect is everyone leaves here and can be able to tell the difference between eating disorders and disordered eating, because the lines can be quite blurred. A descriptive phrase and not a diagnosis. So someone could have certain elements of things that could be similar to an eating disorder, but maybe not have all the points, so not meeting threshold for a diagnosis. The other thing to think about is what is causing the eating difficulties, so the psychopathology behind the eating. We like to sometimes think of it as a bit of a spectrum, because I guess what we know is that eating can be quite disordered in populations like teenagers anyway. So it's a more of a descriptive phase rather than a diagnosis. So there's not actual treatment for disordered eating like there is for eating disorders, and that type of thing. Next, please. So at the moment, we're doing a disordered eating pilot within the 4 CAMS teams or CIP-CT teams. So what this is it's myself as a dietitian, we have a therapist and a pediatrician, and we're trying to do kind of early interventions with young people presenting with disordered eating to prevent things like refeeding admissions, which we often see in eating disorders, or to prevent it from turning into an eating disorder, which can also happen. This is going well so far. We're starting a body image group to kind of go alongside that type of treatment, dietetic appointments to work on the nutrition side of things as well. So that's for the 4 CIP-CT or CAMS teams in Surrey.